I'm Dr. Shivaji Basu. I'm the Director of Urology, Fortis Hospital, Kolkata. Um, Let me talk a little bit about a burning problem now uh, in the world scenario with renal stone disease. Don't know whether it's due to the dietary habit changes or the climatic changes. Now, almost 10 to 15% of the world population is suffering from renal stone disease or the stone in the urinary tract for that purpose. And of that, about 25% will have a relapse after you have treated. And those who have got a strong family history, they can have a 50% relapse rate. So this is quite a problem for the whole world now. And now, initially, we used to do an open surgery to cure the stones. That has been replaced by minimally invasive surgeries like lithotripsy, like ureteroscopy, like PCNL, like RIRS, that is retrograde intrarenal surgery. These actually developed to avoid operation because with that one, there was a lot of time and work time loss for the young people. And that is not possible in this world, in this age. So the concept of minimally surgery unit and surgery came where you can join work within 2 to 3 days of treatment. The diagnosis of renal stone disease has been made easier now because ultrasound is available even in the most remote corner of India, even in Indian villages, where an attack of colic or blood in the urine will make one think that I may have a stone. Let me get an ultrasound done, which are not very expensive now, and it is easily. So, one ultrasound and a urine test will clinch the diagnosis of a stone in any part of the urinary tract, be it in the kidney, in the ureter, or in the bladder. If they are not detected by ultrasound, the other more sophisticated tests like CT scan, like MRI, they have come into picture now, but they are not readily available everywhere. They are ready for tertiary or secondary referral centers. Now, once you detect the stone, how do you treat them? Previously, when we were residents, they're all open surgical methods where you have 5 to 7 days of hospital stay, another 3 weeks of time off from the work, and then you gently go back to the work after 4 weeks' time. So that has been replaced by lithotripsy, PCNL, URS, and RIRS, and for different situations. Which treatment will suit him or her will depend on the size of the stone, position of the stone, the character of the anatomy of the urinary tract, whether there is any obstruction beyond the stone. These are the factors by which we make out which treatment modality is suitable for that person. Talking about lithotripsy, it came to India in about 1985. So it actually started about 10 years before that, but only few centers in the world had the lithotripsy, and that was a huge bathtub where the patient were immersed and the treatment were done. That has been miniaturized to a small 10 by 10 foot room where they can be done as a daycare. So, talking a little bit about the lithotripsy is basically a shock wave disintegration of the stone. This concept is that there is a shock wave generator and surrounding that there is a reflector. The shock wave generated on a focal point gets reflected and converges to a second focal point. Now, if you put a stone, it will be disintegrated. If you put a bone, that will be cracked. So, my job is to find out whether it's a stone or a bone. That is done by the imaging. So, subsequent shock waves will pulverize the stone into powder. This is suitable for any stone in the renal tract in the kidney, which are less than 1 centimeter, or we can go up to 2 centimeter if it is in a favorable anatomic position. But this is a purely daycare center, only a couple of days of rest necessary, and they have to be repeated. They are not suitable for the ureteric stones. For ureteric stones, the technology which is evolved is called URS, that is ureterorhinoscopy. You pass a small slender instruments through the urine passage up in the ureter and pulverize the stone by use of a ballistic lithotripsy, lithoclast is called, or laser in different forms. This has got minimal complications and success rate is very high, contrary to the lower success rate in ESWL or lithotripsy. For the larger stone in kidney, that is more than 2 centimeter or even more than 1 centimeter in a difficult location, PCNL is the treatment of choice. PCNL stands for percutaneous nephrolithotripsy. You make a small hole in the loin and pulverize the stone, and the stone will be either extracted or let go in a powder or dust way. But the problem, PCNL is a sure success. Success rate is highest, about 88 to 95%, but it does have some complications like bleeding. To obviate this complication, nowadays more and more sophisticated equipments are coming, like miniaturization of the nephroscopes from the size of a pipe to a size of a pencil now, and that causes less pain, less bleeding, and the chances of injury to the other structures are much less. But still, we have not stopped there. There are some complications still there, and to tide over that complication, now robots are being used. Medical robotics are being used. This is a precise, this is a dependable, this is stable, and it is reproducible. So the shaking of human hand and all those things are not there. So the punctures, as I said, for the PCNL becomes more predictable and without any complications. So robots are not still used very frequently in many centers, but people are developing the robots in their own way, and purpose-built laser will be treated for the stones. Another thing, development now is navigation. If you combine the imaging with the navigation and tracking, you can actually rule out or eliminate the difference between the structures of the body and the instruments by which you are fragmenting the stones. This is basically using an iPad camera. So if you take the pictures during the operation and then tally with a virtual anatomy in the main screen, the television screen, you can actually overlap the reality image with the virtual anatomical structures, and there will be a precise way of doing a PCNL without complications and with more success rate. So these are the way the stones are being treated. Recently added to this armamentarium is instrument called RIRS, or retrograde intrarenal surgery, done by the use of flexible ureters. Flexible ureteroscopy can go to any corner or any calyces of the kidney and either pulverizes by laser or extracted by using a Dormia extractor. This is useful for any stone less than 2 centimeter, but certainly it has breached the gap of uncertainty in shockwave lithotripsy to the certainty but with complication of PCNL. So RIRS is now the in thing for moderate sized stones, and these instruments are getting thinner and slimmer every day, along with 3D orientations, better imaging, better tactile feedback, so it can cause a precise uh, treatment for the stone disease. To help all those things, we must give full credit to the medical imaging. CT scan was the gold standard, but nowadays, with the advent of more sophisticated MRI, this is becoming more useful because MR can be used in pregnant ladies because CT scan cannot be used in pregnancy. Second thing, MR causes less radiation. So we are getting more health conscious and health safety is given priority. So MR uses of MRI is being more and more introduced with a better machines, with a better Tesla machines. So this is not where we have stopped. There are a lot of work to be done basically to prevent the relapse. These way of treating the stone will completely eliminate the stone, which is the number one criteria to prevent relapse. If there are stones left, then there is bound to be a relapse and another stone. But even if you have completely cleared off, you need to have metabolic studies to find out whether you are a stone former. And for that, appropriate medicines, appropriate dietary advice, and regular screening is necessary to prevent relapse. I'm sure one day we will make the world stone free. Thank you.